dorsal side. All in all, I think this is an aggressive lesion in a pediatric patient. My differentials for this include malignancy such as Ewing sarcoma, osteosarcoma. If the patient is septic, I'll be concerned about infections, osteomyelitis as well. To take this case further forward, I would like to look at any previous imaging, if any, and also advise an MRI. Okay, I've been presented with sequential MRIs of the same patient. The top row demonstrates axial slices. In the top left, the fluid-sensitive fat-saturated sequence. There is increased signal within the central part of the bone and peripherally as well. I think they're all the same sequence actually. And the lateral, sorry, the middle and the right one is fat suppressed T1 and with contrast. And there's a area of there's a ring of enhancement within the medulla of the bone itself, with surrounding high signal in the rest of the marrow. Looking at the coronal images of the same patient, the pre and post contrast images on the right demonstrate the rim sign. I think it's a rim sign as well. And there's an area, a separate distinct lesion more proximally in the radius. And it also demonstrates low T1 in the second image and high T2, or at least high fluid signal in the first image. So given these appearances, I think this patient may have an infective process. I would like to find out if the patient is septic or has got any fever or anything like that. So I think this may be an osteomyelitis. And I'll advise urgent referral to the orthopedic team if this has not already been done.
So anything else in differential?
Malignancy will be there as well. I think Ewing's, I don't see significant periosteal reaction. I mean, I don't think this is a Ewing's sarcoma. It could be a Brody's abscess, osteomyelitis.
Right.
That's what I was thinking of.
Right. Okay. Well done. So the point is that let's go back. Now, there is a lesion here which has got narrow zone of transition, described very well by yourself. And there are differential include. So you use the correct term, it's an aggressive lesion, and the differential of a tumor versus infection, and then asked for an MR. One debating point here will be that your differential out of Ewing's, and initially on the plain film you said one of the differential was Ewing's versus osteosarcoma. So osteosarcoma versus Ewing's, where are you?
So it'll be more Ewing's because it's more in the diaphysis. So your osteosarcomas will be more in the metadiaphysis.
So I think you should have mentioned that, right? So, so the examiner will like that you were thinking, and because of, there is a concept of what we call diaphyseal osteosarcomas. It can happen in 10% of cases, but so you have to tell what are the reasons on which you're thinking. The examiner is, evaluating your thinking. And osseous matrix should be one of the pertinent negatives or positives to be able to differentiate between the two. So in this case, the feedback would be that fine, osteomyelitis was fine, Ewing's was fine, and I think you can say that I did consider osteosarcoma. However, because it is more diaphyseal, more central, that is more eccentric. There is no osseous matrix, so that is less likely. So this thinking process is what they are particularly interested in. Now, uh, now in this case, the learning points here are very, very important for the exam. And these cases will come again and again. Yesterday also I showed you cases, subtle findings on plain film, and then you do an MR. Is it a tumor? Is it an osteomyelitis? And these will come again and again and again. So you have to understand that these two sequences, this is a stir sequence, this is a T1 weighted non-fat saturated sequence. They are the king sequences to look at the marrow. Low signal on T1 and high on stir means edema. There is a sign here which is a penumbra sign. The penumbra sign is which is seen on a T1 weighted sequence. This is a fat saturated pre-contrast sequence, and what I have seen is, because if you look at the soft tissues here and look at the soft tissues here, you will see that the soft tissues appear slightly high signal as compared to this. So there is a bit of physics there. And many people find it a bit confusing. So develop your eyes on a fat saturated. The same thing will occur in the spine also. And then it shows enhancement. Here, of course, there is a cortical breach. There is a soft tissue phlegmon also. So the point is, this is an absolute specific thing. There is a black and white world in radiology, and there is a what we call a gray world. When you are in the black and white world, be confident, and this is what they are testing. Intraosseous abscess. This is an abscess. Penumbra sign, rim enhancement, Ewing's will not behave like this. So keep it to osteomyelitis and do not change your differential, on MR. It was a black and white osteomyelitis case. Okay. Next case, please.
Yep. So I've been presented with axial slices of a very female's lower limb, who is presented with generalized aches and pains. In the top row, it's a fat saturated image, fluid sensitive.
Say again, please. I could not hear you.
Sorry, it's fat saturated. I think it's pre and post contrast actually.
Okay, so these are two stir sequences, and this is a T1.
Okay, sorry.
Bottom.
Okay, let's start again. So axial slices are stir and T1 sequences. In the T1 sequences, I note that there's fatty replacement of the muscles posteriorly.
So where are we?
Yeah, I think I'm having a bit of a mind block.
So
I think it's a femur. Sorry, of course. Yeah. Sorry, this is you're the femur, and this is the posterior compartment.
Yeah.
And the hamstrings demonstrate increased signal in T1, and there is high signal in the stir images. These are in keeping with denervation type of injury, possibly. I would like to ask about any previous.
So denervation bilateral.
Sorry, I take that back. I think this could be because of a DOMS type of injury where the patient may have had strenuous activity when they're not used to it, and subsequently got these appearances in the MR scan.
Then why will there be atrophy? So this is a case sent by the rheumatologist.
Okay. So I think going back to first principles, I note that there's edema in the muscles, and there has been a chronic picture with fatty change of the muscles as well, especially in the posterior compartment. Given that the patient is coming from the rheumatology clinic, I'm thinking of global systemic illnesses, which may be giving this appearance. Um, the this patient could have, I'm not sure about this, but it could be a lupus type of picture or sarcoidosis. I think more lupus and dermatomyositis are my two
Okay,
main differentials.
okay, right. So the point is that this is myositis, and myositis is an exam case. Why is it an exam case? Now, in myositis, when the patient comes to the rheumatologist, they will send, they do, CKs and all those things, and they will send the patient for MR. And key concept which you have to remember for your exam is that the sequences for myositis which we do are just STIR and T1. That's all. You don't need to do anything else. If the weakness is around the pelvis, etc., the pelvic girdle or the shoulder girdle, whatever. And initially, what happens is that there will be high signal on the STIR sequence, and T1 will be irrelevant, if it is an acute case. Gradually, what will happen when atrophy starts developing, there will be fatty replacement. And gradually, the signal on STIR will decrease. So, high signal on T1 will be because of fat replacement. When the rheumatologists send you these cases, and this can be a potential viva scenario, they want you to tell them which group is involved, because the ultimate diagnosis is based on a muscle biopsy. So they want you to tell them, let's say this is quadriceps or this is hamstrings or sartorius or whatever. So in this case, what is happening? This is sort of chronic, so myositis, and some of the muscle groups which are still actively involved. So, for example, left thigh and right thigh. So these muscles are actively involved. Hamstrings, on the other hand, less involved, and there is a bit of atrophy also. So myositis, please remember, is an exam case. Yes, please.
Okay, so this is a frontal AP projection radiograph of the 8-year-old female patient's pelvis. She has dementia, fever, and bed sores. The radiograph is grossly abnormal. I'll start with the right femur, which has got, if the patient hasn't had any previous surgery, the femoral head has been osteolized, or they may have had a girdle stone surgery, possibly. Actually, I think there's hint of a femoral head projected over the proximal femur. So I think it may have been fractured a while back, and there is subsequent dislocation of the proximal femur. The inferior pubic rami are also significantly not lytic, but they've lost their osseous component. Um, and I'm looking, I think there's significant gas within the soft tissue projected over the right side as well.
So what is your conclusion?
Yeah, so with this plethora of findings, I think this patient has got osteomyelitis um, and osteomyelitis and a septic joint as well on the right side.
So how will you confirm that?
Um, I think this can be seen with clinical examination as well, but I think this patient should get a CT or an MR, CT ideally, given that she may not be able to sit still for too long in the MR. Please have MR. Yeah. Just taking a quick look at the MR sequences. In the top two is a T1 weighted sequence, and it's fat suppressed on the second two columns. On the right side, I note the um, low signal intensity throughout all the sequences in keeping with gas, which has been seen on the radiograph. Um, in the
So these ones are post-contrast.
Yeah.
These are T1 non-fat saturated.
Yeah.
Again, same. And this one, for example, is fat saturated pre-contrast T1. So
so looking at the pre and post contrast images, I know there's a significant signal enhancement around the proximal aspect of the femur, and there's high signal within the femur as well. And there's low signal in the corresponding areas of the proximal femur on the T1 weighted sequences. And I think overall, this patient has got areas of osteomyelitis within the femur and surrounding soft tissue enhancement in keeping with a collection or a abscess formation there. This patient would need urgent orthopedic review and debridement as well.
right. So you described this well, and the key finding here was this gas. There should not have been any gas here. You picked up well that this is, in a way, septic arthritis. Now, the same thing is here. One thing which I want to point out, and this is what I'll show to you in spine also. The word phlegmon versus an abscess. And this concept is very important. And in the spine, they will ask you in the exam cases, why? Because it becomes a very important concept in your clinical context. Anywhere where there is inflammation, there will be enhancement. Just remember it like this, that this is, enhancing inflammatory tissue. And at that point, there is no pus formation. When there is pus formation, then there is an abscess, which is liquefied. Pus will not enhance. So pus will become drainable. So this concept is asked in the exam many a times. In head and neck, subperiosteal abscess of the orbits, or in the spine. If something is totally enhancing, there is nothing to be drained. In this particular case, there is extensive phlegmon. You can use the word when muscles are enhancing or they are high signal on stir, call it myositis. Myositis means that this is, infective myositis. But as far as liquefaction is concerned, maybe one can argue there is a bit of liquefied material here. There is a lot of gas because of the gas forming organisms. Otherwise, you don't see much liquid there. So, and of course, there is osteomyelitis also. So I will now show you a case in a sort of a PACS format, like yesterday. So, and I would like you, just 1 second, I think I have not shared it correctly. Can you see?
Yep.
Right?
Okay. Yep.
So let me give you. Have you taken over the mouse? Yeah, just stop here, please. Go to the X-ray. Go back. Okay, yep. Now this is, please begin. This patient, can you go back to the history, please?
Will do.
72 female, history of fall, pain in left hip. They are basically worried about a fracture neck of femur or things like that. Please go to the X-ray.
Okay, this is a frontal radiograph of this lady's pelvis, and the queries of a left neck or femur fracture. Having a quick look through in my usual practice, I also look at orthogonal views as well to aid my assessment. The Shenton's line on the right appears preserved. I think there may be some irregularity on the left side, but I'm not 100% sure. There may be a slight angulation here, which may indicate a fracture. I'm looking for any loosened areas or abnormal bone density. I don't see any asymmetry compared to the other side. And I don't see any obvious fractures of the pubic rami bilaterally. And I don't see any soft tissue abnormalities. Slightly more increased, excuse me, I think there's slightly more increased soft tissue density on the left compared to the right. This could be a hematoma possibly, but to take this case further forward, I saw the MRI, so I think MRI will be indicated.
Right. Okay. Anything else on this film?
I noticed some density there. That could be a calcified fibroid.
There is a swelling on the right side, clinically speaking.
On the right side.
Yeah.
So I mean, I was looking at this area, which is a bit more. There's an increased density going from the iliac ASIS down to the greater trochanter here, which is not visualized here, but it could be just cut off. And there's slightly more increased density.
Right. Okay. Let's go to the MR.
Okay. Shall I move it? Yep.
Yes, please.
So this is a fat suppressed fluid sensitive sequence, a STIR. I'll just start with the left side first. There's increased signal within the greater trochanter, and there's fluid around the joint itself and in the muscular fascial layers. I don't think there's a fracture there, but I'll look at it on a T1 weighted sequence.
What's happening on the right, that soft tissue which you were saying?
So on the right side, there is a low STIR signal, fairly well circumscribed lesion lateral to the femoral head, the acetabulum, and is below the gluteus muscle, and there's some fluid surrounding it. This appears to have been present for a long time. I don't think it's something acute. I wonder if this is a Morel-Lavallée type of lesion, but it's quite deep actually. But I'd like to take a look at further imaging and give context.
Go to the next series.
Okay, so what I said earlier, the previous one was a fat suppressed sequence. This is non-fat suppressed, and it demonstrates high signal intensity within this lesion on the right side. And looking at the left greater trochanter, I think there may be a fracture there actually.
Right, next series, please.
So in this axial non-fat suppressed sequence, this is a T1. Just looking at the left side first. I think there's probably a fracture in the greater trochanter, and this is a lesion which is below the muscles but overlying the joint itself and the iliac crest. I think this is a intramuscular lipoma, which is well septated and long-standing. So to take this
What do
case,
you think, it is benign or malignant, or?
if this, I don't think this is malignant. I don't see any acute.
How will you tackle this one, this lesion? Go to the next series, please.
Yeah, I will do. So
So
this is
what kind of sequence is this?
so this is a fat suppressed T1. I think this is
So just to make a point, because of time factor, I just want to crack on. So that lesion suppresses. Just give me your final opinion on the lesion on the right side. How are you going to tackle this? What is this?
so I think this is a lipomatous lesion within the muscle. It doesn't have aggressive features, but this would still need a biopsy to ensure there's no malignant tissue within it. So I advise that to the clinical team and advise
Okay,
a referral.
okay. I'll take over.
Yeah.
Now, what we have learned from this case is that this was again same category of a case where a sort of a satisfaction for search type of a case. If you see here, part-2 type of fracture, neck of femur, intertrochanteric type, you could have suggested on this plain film also. Now there is a lesion, very difficult to see, but when you look carefully, look at this. This is low density. Lipomas, please remember, have come in even rapid reporting, and so the point is that the key thing is that you will see low density on a plain film. Now, on the stir sequence, fracture lines are at times better seen on T1, but when you see edema like this, you should be thinking fracture. And here, the point is that you have to tell the examiner that I want to see the T1 to confirm it. I'm worried about this. Now, as far as this lesion is concerned, the Viva points, because yesterday I told you that liposarcoma, frankly malignant, is an exam case, and lipoma is an exam case, and atypical lipoma or suspicious lipoma is also an exam case. Now, if you go back to the basics, size is a criteria. Anything more than 5 centimeter, it should be taken, suspiciously, but that is not a very good criteria. We see so many lesions. But having said that, when you see septations, so you should have picked up septations here. These septations up to 2 millimeter is taken as, upper limit of normal. So maybe on radiological grounds, it is still within, benign limits, but the size is quite significant. So key point is that sarcoma should go to sarcoma center. You will never ever advise a biopsy. So just like a bone tumor, you will ask that it should go to the sarcoma center. And there are many pitfalls. What they do? They don't even do biopsies for these kinds of, they just take it out. There are a lot of pitfalls in biopsies where what happens is that you take a sample from a region of the tumor which hasn't got a malignant component, and you might get false assurance. So if they decide, they discuss with the patient to take it out, they take it out, and the biopsies are done later on. On the other hand, frankly, radiologically speaking, malignant lesion, they might do a biopsy because they might change their surgical plan accordingly. So the answer here is that I will send it to sarcoma unit, sarcoma center.
Sorry, I should have mentioned that. I think they would advise you rather than myself. Apologies.
Yes. Okay, well done. So we go to candidate.
Thank you.
Okay, well done. So candidate 2, are you with us?
Yes, hi.
So I am going to give you pain in the left thigh is the clinical. So let me give you the mouse. Over to you.
Okay.
Just stop here and please describe this.
Okay, so I have a radiograph of the left femur in a 5-year-old female patient who presents with pain, and I can see in the mid shaft of the left femur an eccentric lesion, which is lucent, well defined, and has secondary associated cortical thickening. I can't see any associated aggressive features such as an aggressive periosteal reaction or soft tissue component. I can just see smooth cortical thickening surrounding this lesion. There's no other abnormalities that I can see. Overall appearances are of a non-aggressive bone lesion. Given the associated cortical thickness present in this radiograph, my top differential would be an osteoid osteoma. I'll correlate with the history to see if the patient has night pain and if it's relieved by aspirin. And I would recommend CT evaluation to look for anitis.
Okay, let's take there was, I think, another film. Go to the next slide, please.
So on the lateral radiograph, the lesion appears to be cortically based. Again, I can see some cortical thickening in the area of lucency within the lesion. There is maybe some loss of the cortex. I can't see any other abnormalities. So I think findings are in keeping with a cortical lesion, and my top differential will be an osteoid osteoma.
Okay, let's go to an MR. We've got an MR. You can scroll through. What sequence is this?
So this is an axial fluid suppressed, fat suppressed sequence. So a stir most likely.
Okay, please continue to the next series. And what is this sequence?
T2 weighted imaging.
Is it T2?
It's actually a T1. It's just the marrow looked a bit darker than usual, but it's a T1 axial.
Okay, talk about the lesion on this one.
Okay, so there's abnormal marrow signal in the left femur, and I can see a central low signal intensity within on the left hand side, surrounded by more normal signal. Just looking. It appears to be focal and not diffuse. There's no.
Okay, next series, please. Let me give you another series. Yeah.
So this is a post contrast.
This is a fat saturated, right?
Okay.
Pre.
Okay, so again, I can see abnormal signal here. So this is a T2. So the T2 weighted sequence, I can see an abnormal circumferential soft tissue signal surrounding the left femur. It circumscribes the whole of the left femur and extends a few centimeters down.
Okay, next series, please.
Okay. So in this sequence, I can see what appears to be a cortical breach, and on this aspect here, with a low signal intensity, and again a abnormal signal circumscribing the femur.
So what is your conclusion?
I think given the cortical breach and the abnormal signal surrounding the left femur, I wouldn't really expect that with an osteoidostoma to see abnormal signal in the soft tissues as present on this image. I think I would have to include things like aggressive processes such as an osteomyelitis picture, given this appearance with cortical breach and an associated soft tissue component.
Okay, thank you. Thank you. I'll take over. So, if you see here, now the point is that look at this lucency. And this lucency is not like nidus. So it is fine because this is a solid type of periosteal reaction. So to think that it might be because it is cortical based, but this, the shape of this is not like nidus. Having said that, on the first film, it's a tricky one. But on the second film, it is diagnostic. Now, what is happening here is, if you see this bone here, this is sequestrum. This is dead bone. And this is a key finding. And so there is a breach here. Tunneling, cortical tunneling is here. And so, on a plain film, I'm expecting you to pick this up and say that this is osteomyelitis, chronic type of osteomyelitis. And then everything, the axial sequences are very, very good. Now, to make this diagnosis, this is a T1 weighted sequence. Now, you can see that there is cortical thickening. And here comes that sequestrum, which is sitting inside this. And even here now, you can see that breach, which you picked up on contrast. So the marrow here is normal, but at this point, it is, of course, encroached and abnormal. And the same finding of, the sequestrum is a key finding here. And then on this T2 is very good because you can see this fluid. And this is means that this is a soft tissue abscess, which goes and surrounds it, and which also showed enhancement. So the component which is not enhancing, which is this one, will be abscess, and the surrounding component which is enhancing is a phlegma. So osteomyelitis. Okay, fine. So let's go to yes, please.
I can't see the screen.
Sorry. Now you can see?
I can see multiple. Yeah, now I can see.
Okay. Over to you.
Onto radiograph of the left humerus. In the left humeral metaphysis, I can see a medullary-based ill-defined lesion with a wide zone of transition. This is associated with a large soft tissue component. There are also areas of what appears to be some periosteal reaction. It doesn't appear to involve the joint space. I'm concerned about an aggressive lesion in this patient. My top differential will be an Ewing sarcoma given the soft tissue component. Osteosarcoma will be less likely given the lack of new bone formation. I would recommend an MR evaluation.
MR for you.
So I have selected T1 weighted T2 and STIR images, as well as axial and sagittal sequences. So I can see a large soft tissue component, which is...
just to highlight, this is a T1 and this is a post-contrast.
So I can see a large soft tissue component surrounding the left humerus. The lesion is iso-intense to muscle on T1 and demonstrates significant soft tissue enhancement. I can also see a medullary-based lesion, which is of heterogeneous signal. Putting this all together, it's in keeping with Ewing sarcoma.
Will you keep osteomyelitis in your differential?
I think osteomyelitis would be less likely given a large soft tissue component within it, but I would correlate to the patient's symptoms to see if they have a fever, if they have a high white cell count or CRP count. But I think Ewing sarcoma will be the most likely differential.
Okay, so one key thing to remember is that Ewing sarcomas and osteomyelitis, both of them clinically can present the same way. And Ewing sarcoma, the patient can have fever, can have raised ESR, leukocytosis, etc. So clinically speaking, you can confuse the both. Now, in the real world, what happens is that there are black and white cases and there are gray cases where you might end up doing a biopsy. But I have shown you a black and white case, the first case which I showed you, that Brody's abscess with penumbra sign, etc. So then that is osteomyelitis. And on the other hand, this is Ewing's. And so here you did well. There is, permeative bony destruction, a wide zone of transition, soft tissue component. Here, the key finding is that look at this soft tissue. All of this is enhancing, and you did very well where you picked that up. And disproportionate thickness of it. There is no, abscess formation, intraosseous abscess, or periosteal abscess, soft tissue abscess. So if you see an intraosseous abscess, just like you saw the first case, which we did cover today, then you are very confident about osteomyelitis. So this is Ewing's, and call it that, if an examiner is grilling you, for example, I asked you a leading question, can it be osteomyelitis? Then your confidence should still be there. You tell the examiner you're thinking, can it be osteomyelitis is my question, and you say that given that there is disproportionate soft tissue swelling, given that there is no intraosseous abscess or periosteal or soft tissue abscess, this is unlikely, and my principal diagnosis remains Ewing's. Easy, just give me the diagnosis. Sorry. Are you with us? Can you
yeah, yeah, so there's okay, so 8 months with left hip pain.
Actually, this is 8 male.
Okay.
So 8 years. 8 years.
8 years old. So I can see abnormal marrow signal in the left hip joint, which extends into the joint. I can also see the epiphysis also appears to have an abnormal appearance. It appears to be sclerosed and with some collapse of the left epiphysis. So is this Purphy's disease?
Yeah, simple as that. And you can see that the epiphysis is collapsed. It is smaller in size. It is low in signal. And similarly, a scaphoid fracture has come in the exam. So it's very easy that it will be low in signal. And when it becomes chronic, it will be low in signal on T1 and low on stir. When it is more acute, it will be low here and high on the stir sequence. This is your last case.
Okay, so we have a radiograph of the left tibia in a child, and in the proximal diaphysis, I can see a lucent lesion within the medullary cavity with ill-defined borders. There's an impression of an increased periosteal reaction, which is smooth. Appearances are in keeping with a non-aggressive lesion in the left proximal tibia. I'd like to have a look at the lateral to further characterize this lesion. So the lateral demonstrates similar findings of a lucent lesion. It has a partially sclerotic border, with the more anterior border less well defined. There's increased cortical thickness within this area, and I think there's also increased sclerosis more inferiorly as well. I think I can see a possible nidus in this region here. It's more convincing for nidus than the first case, and the cortical response here appears to be quite smooth and well defined. So I think given these appearances, I will correlate with the history to see if the history will be in keeping with an osteoid osteoma in this case.
So what are you going to do next?
So if the history is typical of an osteoid osteoma and they do have night pain relieved by aspirin, I'd recommend a CT.
CT.
Okay. So this is not. So this again has characteristics of osteomyelitis. I can see cortical breach with a cloaca and cortical tunneling with a sinus which tracks the muscles. So osteomyelitis.
Here you are. So I think you got, I think 2 or 3 or how many osteomyelitis. So hopefully you'll get one in the exam also.
Yeah, fingers crossed.
Yeah. So the point is that if you see on this AP view in the real, when you are on a DICOM viewer, you can ask the examiner to, I will like to slightly change the density. And if you look carefully, you know, it is tunnel shaped. Though on this exposure, it's difficult to pick up, but here, definitely, you see it is tunnel. Cortical tunneling is specific sign of osteomyelitis. Tumor will not do it. If you see cortical tunneling, and with that, you see this thickening of the periosteum, you know, call it. It's an absolute specific sign. So, of course, on MR, it was slam dunk. It was, you know, absolutely clear. So this is cortical tunneling. Thank you very much. Candidate 3, are you with us?
Yeah.
Yes, please.
Sure. So this is a 9-year-old with pain and swelling, and this is a frontal radiograph of the left upper arm. So I can see there's area abnormality in the shaft of the humerus with cortical thickening, and I can also see that there's area of periosteal reaction. And looking specifically at the abnormality, I can see there's mixed lucent and sclerosis with white zonal transitions. However, I cannot appreciate a adjacent soft tissue next to the bone, and overall finding is pointing towards an aggressive lesion.
Can you describe this periosteal reaction? What type of periosteal reaction it is?
So this has it's like a laminated periosteal reaction.
Okay, So you're right. Onion skin type. Okay. What is your differential here?
So my differential includes Ewing sarcoma.
What were you going to do next?
So MRI of the upper arm. So these are selected images of the MRI of the patient demonstrates marrow signal abnormality with high T2 signal within. And I can also see there is laminated peripheral.
And this is a stir. So on T1 it is?
It's low T1 and also high stir signal within the marrow.
What's happening on these sequences?
So on the axial images, I can see there is onion skin peripheral reactions in keeping with new bone formations and also a surrounding signal abnormality in the musculature.
Right. So the final conclusion?
So this is a Ewing sarcoma, finding out most in keeping with Ewing sarcoma.
Okay, fine. So another example, and so just to make the point, it was much easier. It was not a settled case. It was quite an obvious case. And just to make that point that this soft tissue component, again, and Ewing's.
So this is a 9-year-old male with leg pain. I can see this is frontal and lateral radiograph of the right lower limb. I can see the area of abnormality at the distal shaft of the right femur with cortical expansions and radiolucent area. And looking at the cortex for any periostal reaction, I cannot appreciate any periostal reaction. However, there's a impressions of a soft tissue component adjacent to this bone lesion, and it has a wide zone of transition. Overall features is pointing towards an aggressive bony lesions. My current differential includes an osteomyelitis or a primary bone tumor.
What will you do?
In my normal practice, I will organize an MRI for this patient. So this is selected images of the MRI of the lower limb for this patient. I can see there is signal abnormality centered in the marrow and also an adjacent soft tissue mass with cortical bridge. And this soft tissue mass is rising from the marrow, and there is also some fluid levels seen. There's a question whether this is the ABC, but I think overall finding is pointing towards an telangiectatic osteosarcoma with fluid level.
Excellent. So yesterday I showed you a case of fluid levels in an aneurysmal bone cyst, and you know, in this case, if you go back to your Chapman and see the differential of fluid level, telangiectatic osteosarcoma is given there. So if you see here, there are fluid levels, but the key finding is that of course the appearance on plain film was also different. But look here, look at this intermediate signal. This is all solid component. This is all solid component. So don't think that if you pick up fluid level, it will always be benign. So this was a telangiectatic osteosarcoma. Dr. Butt's lecture.
As a 61-year-old with shoulder pain. So selected coronal and also sagittal and axial sequences of the shoulder. I can see there is fluids in this bursa, and there is also glenoid cyst in intraspinatus atrophy with fatty signal change in the muscle belly.
Is it infraspinatus?
On the sagittal, I can see that is supraspinatus.
Supraspinatus.
Yeah.
Please continue.
So there is fatty atrophy of the supraspinatus. So I'm looking specifically at the insertion point of the supraspinatus. And because this is suggestive of a full thickness tear. So on the first image on the left top region, I can see there is a full thickness tear of the supraspinatus with a big gap. So overall finding is in keeping with a supraspinatus tear with subsequent muscle atrophy.
Okay. Fine. The main point is that this is the glenoid and this is the head of humerus. Now you can see that there is superior migration of the head of humerus in relation to the glenoid. Exam case, they will show it to you in a plain film. For example, rheumatoid arthritis, where there will be superior migration and there might be some clavicular erosion also. So they will show it on a plain film. So please remember this concept that you can sort of infer a full thickness tear or a massive tear just by looking at the configuration of these two and the history or etc. Now what is happening is that this is the supraspinatus component of the rotator cuff. It goes from here and should have been attached here. There is nothing here. So in your pertinent negatives and positives in your description, please remember they will give you some marks for that. Even if once you get the diagnosis, you are passed, but your endeavor is to get more and more marks. So there is a massive full thickness tear with retraction of the musculotendinous junction. So it is retracted here. It is sitting here actually. It should have been here at 12 o'clock position. So in your clinical practice, actually you measure it also, but not in the exam. We measure it in two sequences. One is coronal oblique and then is sagittal, and we measure it like this from here to here and then from here to here, and tell the surgeons that mediolateral is this much and AP is this much full thickness tear. And retraction of the musculotendinous junction is very important. As you have pointed out, atrophy of the muscle is very important. They might not like to do anything about this case, surgically speaking. There is fluid in the subacromial subdeltoid bursa, which is in communication with, and there is fluid in the glenohumeral joint. So all of these findings should be there so that you get maximum marks. And there are some degenerative changes at the AC joint, and this might have been causing the initial impingement, which has caused all this. And there is a bit of cortical irregularity of the greater tuberosity of humerus. So this is a massive full thickness tear. This is an exam case. Similarly, the second exam case in shoulder is recurrent shoulder dislocation, in which there might be a full thickness tear, might be a partial thickness tear, with that Hill-Sachs lesion, with that Bankart or a bony Bankart. Please remember, Hill-Sachs lesion, the examiner is going to start with an axial. And the key thing is, as you were told today, that the rounded appearance of the head of the humerus, that becomes distorted on an axial. So I warn you that they will start with an axial regarding Hill-Sachs. The last case for you will be a sort of a PAX type case. This case, I am going to just ask you a question. There is a lot of abscess formation here, and there is a, what is this?
So there is a fluid level, and
compare it with this one.
Compared to the.
Okay, so this is a T1 weighted sequence.
Yeah.
And this is a fat saturated stir sequence.
Sure. So there is fat within this
How do you explain this? What is the inference of this?
So that means the marrow fat has escaped and...
Excellent. So is there also...
Hello?
osteomyelitis or not?
Yes, the presence of fat indicates that the marrow has been involved.
Yeah. So this is taken as an absolute specific sign of osteomyelitis. You will rarely see it. Of course, you can infer, there is destruction and all those things of the cortex, etc. But if you see fat, means the fat has come out of the bone. So very rare to see it. If you see it, if an examiner has got this kind of a case, you should know this finding. So scaphoid fracture, I'll just skip it because there is nothing much here. Classical viva where you say that there is a suspected fracture and clinically there is no fracture correction. There clinically you are suspecting a fracture and X-ray is not. So candidate 3, what is your clinical practice? What do you do?
Repeat X-ray after 10 days because in my institution we don't do MRI yet.
Right, a good answer. So basically you treat it as a fracture, you put a back slab, send the patient home, repeat it after 10 days. As was pointed out in many centers in UK, now we are doing MRs there and then instead of waiting. But in many centers, of course, availability and capacity and all those things are also there. So these cases have come in the exam quite a few times. They are easy cases. They can also come in rapid reporting. Avascular necrosis, for example. What are the signs of avascular necrosis here, candidate 3?
So there's increased sclerosis and also fragmentation.
Right. And on this T1, what is happening in the proximal pole?
So in the proximal pole, there is increased T1 signal and also discontinuations of the cortex and the fraction line seen through in the at the waist of the scaphoid.
So you mean to say there was decreased signal on T1, correct?
Yeah.
Yeah, okay. So decrease on T1 and high on stir. But on this side, which was distal pole, you can see the signal on T1 is not all that decreased.
Yeah.
Spine, I will start tomorrow. So I will give you 9, 10, maybe one case of on PACS format, right? And then we will stop. Can you see this case 7 written?
Yes.
So let me give you the remote. The patient has got diarrhea, fever, pelvic pain, 63 male. Actually, they were worried about something like UC, etc. They did a plain abdomen. Go to your first pair.
I don't think I have got the control yet, right?
Okay, you don't have control. Okay.
Yeah,
Now,
got it. I think, yeah.
okay.
So this is frontal radiograph of the abdomen of a skeletally mature patient. Demonstrate non-specific bile gas pattern, no bowel obstructions, toxic dilatation or perforation. And looking at the skeleton of this patient, SI joint is unremarkable. And looking at the hip joint, there is in the right hip there's reduced hip space, hip joint space, and also increased sclerosis of the acetabulum and also the femoral head. In my normal practice, I'll look at previous radiographs just to see if it's a new finding. Given that patient has got a septic picture and with a pelvic pain, this is concerning for septic arthritis.
Go to next case, please.
So this MRI series 1. This is coronal T1. So I can see there's abnormality centered at the right hip.
And keep going. It's an easy case. Keep going to the next series. What's happening on this T1?
So there's reduced signal at the femoral head and also the acetabulum.
Next, please. Next, please.
It's axial.
Pre-contrast T1.
Okay, pre-contrast.
Saturated. Post-contrast. What's happening here?
Oh, did I scroll too fast? Oh, yeah. So I can see there's enhancing what appears to be a collection at the adjacent soft tissue. And also there is enhancing.
Yeah.
So that is the, so we have.
So what is the conclusion?
So this is overall finding is septic arthritis.
Okay. I will. You keep the mouse, but I am going to just. Okay. So well done. If you see here, look at the findings of now. The key finding here is, as was pointing out, that the joint space is lost. But then look at this. Look at the margin. This margin is lost. Now that has to be pointed out. Similarly, there is a bit of depression here and a bit of lucency here. So these things then become suspicious. Having said that, the key thing here is that observation, which you picked up very well, that something is happening in the right hip joint. If the history is not given, then the examiner will give you a hint and you pick it up. The key point here was that we picked up septic arthritis in a plain abdomen fill. So, and this is what satisfaction of search, your protocol, you have to look for each and everything. And on this coronal post-contrast, it becomes a very easy case. Okay, let me give you the last case of the day. 21-year-old female, mid-foot pain and tenderness. Next film, please.
I think I lost the control to. Oh no, sorry. Yeah, I do have. Yeah, okay.
Please go back. Go back. Yeah, just stop here. This is your first film.
Sure. So this lateral radiograph of the left foot of a 21-year-old female with a mid-foot pain. I'm looking specifically at the pressure point at the metatarsal head and also the calcaneum. And this on this radiograph, I can see there is a high arch of the calcaneal at the midfoot. And I do not see any sign of acute bony injury on this radiograph.
So, what is happening here?
Sorry, I can't see the cursor.
So, leave it for me. Leave it for me. What is happening here?
Here.
Excuse me. Can you hear me?
Yes, I can, but I can't see the cursor.
You don't touch the mouse. I am taking control and I am asking you a question.
Right, okay.
What is happening here? Can you see my mouse?
No.
No?
Yeah.
Oh,
No, I
really?
can't see it. I think, are you pointing at the talocalcaneal?
This is my question to you.
Right.
Exactly. So this is what I'm asking you. What is happening here? What is happening?
So there's beaking of the talus.
Right.
In keeping
Right.
with talocalcaneal correlation.
Talocalcaneal correlation. Talocalcania. Okay. So what are you going to do next?
So this patient is symptomatic, and I will review the remaining images of this radiograph. And this patient will need a referral to orthopedics team for assessment.
Would you like to see another view?
Yeah.
Okay. So this is another view.
So noting that the patient has got midfoot pain on this view, I can see there is abnormality centered at the second toe metatarsal head with flattening
okay.
of.
We knew that. The patient had known AVN there. We knew it since last 3-4 years actually. So we are not interested. Your finding is correct. Your finding is correct. This one.
Right. Okay. So on this view, I'm looking at the midfoot congruency of the Lisfang joint. It is normal, and looking specifically at the calcaneotalar alignment, there's increased sclerosis at that point, and on the lateral view, I established that there is a correlations at this point, and given that
this is excuse me, this is an oblique and AP. Were you mentioning the previous view which you saw lateral?
Yeah.
Okay. Okay. You are worried about the collation, and you think that there is a collation talocalcaneal. Did you pick up on, let's say, on this one?
Mm-hmm. There's another finding. Is that right? The C sign.
You're talking about this thing.
Sorry, for some reason on my screen I can't see the pointer.
Okay, what I will do is I'll take the control from you because I think it's giving us problems.
Okay.
So now.
Yeah, I can see it. Yeah.
Now, this thing is the C sign you are pointing out?
Yeah.
Okay. Now, on these views, do you see? So you are worried about talocalcaneal collation. My question is, on these views, do you see anything to confirm your diagnosis?
So on the oblique view, I can see there is loss of the normal joint space between the talus and the calcaneum.
Oblique view is just like this, because it is projected like this. Okay. So I'll come back to this. What would you like to do next?
So doing an MRI would be helpful to look at the underlying.
So you keep looking at this MR, and okay. I am scrolling it for you.
Okay, there's signal abnormality.
Excuse me, keep looking, because of time factor. I'm going to go through it and keep looking, and then you will tell us your findings. Yes, please. What is your finding?
So I can see there's fluid at the tendon of the.
Where are we here?
So this is the that is the talus, and that is the continuation into the calcaneum. So
have you confirmed your diagnosis?
Yes, I have.
So what, anatomy wise, where is this? I am talking about the subtalar joint, and I want you to name names here. Which component of the subtalar joint this is?
Medial process of the talus.
The same thing here. Okay. So there is talocalcaneal collation, but I will go through it, and Please remember, it's a very important exam case. And I'll tell you what are the viva questions which will come from this. Now, the key finding is that when there is stellar beaking, the clinical, keep your eye open about the clinical. Young patient with this kind of a thing, the examiner is going to initially start with a lateral. And on a lateral, the main thing is this thing, talar beaking. Please remember that talar beaking is not a specific sign for talocalcaneal collation. If you go back to the basics of collation, most common and equally most common are talocalcaneal and calcaneonavicular. So in both of them, the dynamics of the foot is deranged, and that is why there are, talar beaking. It's sort of a degenerative change here, which should not happen in this age group. Once you pick that up, you start thinking what is happening. If you see in this particular case, there was a C sign or reverse C sign, whatever you want to say. Please remember, collations are three types, osseous and cartilaginous and fibrous. So when there is osseous collation, then you will see this C sign, I'm talking about talocalcaneal. Now, key viva question here is, what would you like to do next? And the examiner is asking you plain fill. Still you are in plain fill. And here you have to remember that I have not shown you, but for talocalcaneal collation, the axial view of the calcaneum, that is the best view. And why is that the best view? Because it shows you the subtalar joint. Subtalar joint has got three facets. One is anterior facet, second is middle facet, and then is posterior facet. The collation is most common in the middle facet. By the way, the others can also be involved, but most common in middle facet. And this is where the sustentaculum tali, that is where the facet joint is. You can pick it up on an axial view. So please remember, this is a classical viva scenario that once talar beaking is there and the examiner shows you oblique view, if there was calcaneonavicular collation, it would have projected here and you would have seen it. So oblique view for calcaneonavicular collation. But for talocalcaneal collation, ask for an axial view. So that is a classical viva scenario. To confirm it, you can do a CT, you can do an MR. These days we do MRs more commonly. And in this case, you can see this bone going and connecting here, but the king sequence here will be the coronal. And anatomy-wise, this is what the examiner is going to ask you. And you see, this is the middle facet, and you can see bone connecting to the bone. So the same thing, of course, can be seen on a CT. And then the most important viva question. The examiner is going to ask you, what will you do next? So I'm going to ask you this question. This is your final question of the day. What are you going to do next?
Because the patient,
yeah, please continue.
sorry. Because the patient is symptomatic from this deformity, so orthopedic referral would be helpful to assess. And also, I'm just thinking down the line of whether there's any surgical correction that the patient can have. But clearly on the MR, I can see sign of tendinitis secondary to this.
So the answer is much, totally different. I am going to do imaging for the other foot. That is the answer. You see, in up to, various series have told us 17 to 35% of these will be bilateral, and you can pick them up incidentally. The patient is living with it. So whenever you find a collation, you do X-rays of the other foot. That is the answer for the exam.